Next up to speak is our neurologist, Dr. Ferrer, and he is super happy to be here. He did his training in the Bronx, and he hasn't had to shovel any snow since he's been here, so Dr. Ferrer, go right ahead.
Thank you very much for that wonderful introduction. I've been in practice for about 18 years. 16 of those years was in New Jersey and New York, and I've been here for the past 2 years, and I'm very happy not to see those blizzards anywhere. This is going to be a relatively short talk on concussions because this will be in tandem with Dr. Walter's talk on sports injury. And so, let's begin. How does that work? Okay, so I will begin this talk with this nice little cartoon. This basically is to illustrate the importance of making a timely and accurate diagnosis with confidence about concussions, all right? So let's start with the definition. First of all, it's important to know that there's no universally accepted definition for concussions, but there are throughout the literature but there are points of agreement, and this is basically a compendium of what the literature is about. Concussion is any trauma to the head causing alteration in mental status with and without loss of consciousness. This is according to the American Academy of Neurology. It's a mild traumatic, both concussion and mild traumatic brain injury are actually used synonymously. Mild traumatic brain injury is the preferred term, preferred nomenclature for civilian and military injury, while concussion is usually used for sports-related injury. And in the context of this talk, we're going to be referring everything to basically concussions. So from a practical approach of looking at concussions, we can look at it any contact head injury with a Glasgow Coma scale between 13 to 15 within 30 minutes after the injury. Moderate traumatic brain injury has Glasgow Coma scales less than 13, between 9 to 12, and more severe is between 6 to 9. So this is the Glasgow Coma scale. I like using what I call EBM. Best eye, best verbal, best motor, and 4, 5, and 6 is the maximum of each for a total of 15. Okay. The incidence of sports-related concussions in the United States is 1.6 to 3.8 million per year. It's mostly seen in contact sports such as football, hockey, soccer, boxing, and it's about 20% per season. Males tend to have a greater predominance for concussions. Some studies go 2.0 to 1 to 3 to 1, and about 50% within the age ranges of 15 to 34. The pathophysiology of concussions, it's basically, if you think about it, it's a mechanical injury. It's any kind of contact to the head. And it could be looked at as the shaking of the brain inside the cranium. The way I've always explained it to my patients is think of a walnut, shake the walnut. The symptoms are basically related to a disturbance of neurological function. If you look at it from the cellular level, it's axonal damage from shearing effects. And if you look at it from the subcellular level, you could think about it as the release of excitatory neurotransmitters such as acetylcholine, and I think glycerin is, and a couple of glutamate is a big factor there, as well as the generation of free radicals. If we look at concussion as a timeline from when the injury begins and later, from the first seconds to minutes or immediately after the injury, we're looking at an altered mental status. We're looking at confusion and amnesia. We have retrograde amnesia, which is loss of memory for the incident prior to the injury, as well as anterograde memory, where it's difficult to lay down thoughts or lay down memory. Minutes to hours after the injury or the subacute phase to the we think about headaches, vertigo, imbalance, nausea, vomiting, and lack of awareness. And from hours to days or the chronic, we're looking for mood changes, cognitive changes, photophobia, as well as underlying sleep disorders. So we should know what are the most common clinical signs of concussion, but I think the most important things are what are the atypical signs of that you could see, because we're looking for ominous signs that are not mild traumatic brain injury or concussions where we have to think of more serious conditions. And those are hemiparesis, the visual field deficits, and pupillary changes. Post-traumatic seizures occur within the first 7 days after the concussion. It's less than 5% in most cases. There is a 25% risk of developing epilepsy or seizure disorders in some of the post-traumatic seizure cases. Putting them on anticonvulsants will not change that the frequency risk. Moderate traumatic brain injury is intracerebral hemorrhages with Glasgow Coma scales of less than 13. To evaluate these patients, patients must be seen by a medically trained provider, which could be seen in the clinic, the office, the emergency room, and conveniently on the athletic field. Loss of consciousness of greater than 1 minute, persistent altered mental status, abnormal neurological exam requires imaging and a neurological or neurosurgical consult. We're again looking, there are a lot of studies out there that assess mental status, but the most important thing is that we should assess short-term memory, attention, and concentration. Those are the basis of the mental status examination in concussive injury. Non-contrast CT scan is the preferable study within the 7 days during the acute phase, and MRIs would be for the subacute and chronic stage, because the MRIs can pick up things like axonal shearing and hemosiderin from blood, from bleeding. There's several guidelines on when to image patients, and the American Academy of Emergency Physicians, they adopt the NOC, or the New Orleans criteria, and it's basically any kind of blunt trauma with a Glasgow Coma scale of 15, with a normal neurologic examination along with these other symptoms. Now, to make a firm diagnosis, again, it's any head injury with and without loss of consciousness. It's very important to understand it. A lot of concussions are without loss of consciousness, but with the mental status change, which include memory loss, confusion, and again, a Glasgow Coma scale between 13 to 15, approximately 30 minutes after the trauma. So after you've comfortably diagnosed a patient with a concussion, what do you do next? And you've imaged them and they're pretty stable. Well, within the first 24 hours, we do recommend observation. What that means is that it's rest, physical rest, and cognitive rest. It's either at home or at the hospital. There are certain criteria that require admission to the hospital. That's Glasgow Coma scales of less than 15, abnormal CAT scan, seizures, of course, bleeding diathesis, oral anticoagulation, and neurological deficits, along with recurrent symptoms of nausea and vomiting. So if the patient is an outpatient, of course you should educate the family members and have the family members look for these ominous signs. So when will patients, should athletes return to play or return to competition? Well, the studies have shown that premature return to play or return to competition would actually increase the risk for subsequent concussions. So it's best to have athletes go back to practice or play when they're asymptomatic. That reduces the risks for potential cumulative brain injury, such as the rare incidence of second impact syndrome. There are no evidence-based current guidelines for return to play. Everything is basically consensus. but any athlete that is suspected to have a concussion should be removed from play immediately, and they should not continue practice until all symptoms have resolved. Any loss of consciousness requires a trip to the emergency room. Multiple concussions should be referred to the neurologist or the neurosurgeon for evaluation. Persistent neurobehavioral signs and symptoms should raise the suspicion of chronic traumatic encephalopathy, and they should consider retirement from the sport. That's a whole different topic altogether. So what's the prognosis? The majority of post-traumatic symptoms resolve over a course of a few weeks. In most cases in sports-related injury, it's actually a couple of days. At 1 month, the symptoms are largely improved and they're completely resolved. Symptoms that last and persist greater than 3 months, by definition, through consensus, is considered post-concussion syndrome. But that's but it is the minority. It's about like 10%. One study shows about 20%. Post-concussion syndrome has a lot of, is basically a diagnosis of exclusion because it's a non-specific type of complaints. There are no pathognomonic signs and symptoms that point to post-concussion syndrome other than the time. And before diagnosing post-concussion syndrome, you have to consider confounding factors such as medications, medication effects, mood disorders, other pain-related injuries that could prolong the symptoms. So in conclusion, concussion is a mild traumatic brain injury. It's resulting from blunt force trauma, either acceleration or deceleration. All concussions should be medically evaluated. Any loss of consciousness should be seen in the emergency room department. Any abnormal CT scan or imaging should have a referral to the neurosurgeon or the neurologist. There's 24-hour rest and observation after the injury, and athletes should not return to play if they are symptomatic. Any questions? Yes?
So you've got a patient who clearly has a concussion and had symptoms that have now resolved, let's say within 24 hours.
Yeah.
Or my role as an emergency physician, we'll see a patient who had loss of consciousness, CT was negative, the exam's normal, but they're an avid lacrosse player.
They're avid what?
They're an avid lacrosse player.
Okay.
They're a 16-year-old woman soccer player, and they want to go back to play tomorrow or at the end of the week, but there's no doubt that this was a significant head injury. When would you advise that they could go back? And they are now asymptomatic.
Yeah. Well, what I've always recommended to a lot of my patients with that scenario is that you put them gradually to that pre-injury activity. They did a couple of studies in Mayo Clinic where they separated volleyball players who had that type of scenario where they had a significant injury and they were completely asymptomatic. They wanted to go back. But it turns out that you need that extra rest. And you gradually go through like maybe a week or so. And what I've encouraged a lot of patients who may be symptomatic or asymptomatic is that they engage in some sort of mild cardiovascular exercise, walking or cycling. Because they will feel it. They will feel the exertive, when they exert themselves, they will feel the symptoms come on. And they know, I tell them, listen to your body. But at the same time, do not waste away in bed and try to, and every symptom that you have, you have to baby it. That's,
I'd like you to I'm over here, comment about more on prevention. Many of us have seen the movie, the research on football and that sort of thing. And I'm thinking that they need, rather than an inch or two of padding on their helmets, they need about 6 or 8 inches that look like Jack in the Box sort of prevention and other things. But and I think more of the sports probably need helmets. I noticed that boys lacrosse wear helmets, girls lacrosse do not. And you comment on more prevention.
By the way, there is no evidence that a helmet is going to prevent you from having a concussion, by the way. In fact, a lot in football, they suggest no helmet-to-helmet contact, no, I think it's helmet guarding. There's certain things that they suggest. In fact, for high school, they really do not recommend children less than 14 years of age to engage in full tackle. They will say, flag football and stuff. And on a general consensus, less than 14 years of age, no contact sports is really recommended because the concussions are far more frequent among kids less than 14. It's basically because of the anatomy. Yeah, over there.
In 3 of your slides, you mentioned that concussion is based on a contact. I will tell you that 11 to 15% of NCAA recorded concussions occur in non-contact sports. And you should be aware of that. In terms of return to play, if you're treating high school athletes, you need to be familiar with the CIF protocol. If you go to CIF and look at the California Federation's guidelines, they are very specific on return to play, and they have to be guided with asymptomatic status, then light aerobic return, then moderate, then severe, then light contact. And you should familiarize yourself with those and not just go on what you think, because there are very specific guidelines out there.
All right, we'll take one last question right here.
Yeah.
So one of the recommendations you made for recovery is mental rest. And I had a young man in his 20s who was actually involved in a motor vehicle accident and had anterograde and retrograde amnesia. He got checked out in the emergency room. He was okay. When I saw him a few days later in my office, he clearly had some not dysarthria, he just had slow speech, continued to have problems in addition to post-traumatic stress from this motor vehicle accident. Anyway, he's a computer programmer. And I actually kept him off for almost a month until I could see that he was functioning well, and then slowly went back to work. And his employer said, "You're really not functioning at the level I'm used to," but they accommodated him, and he's gotten better over the next month or so. What do you say about mental rest?
Well, it's funny because we've done if you do cognitive testing on these people, they are a little bit slower than they usually have been. And again, that's really based on the individual and how, or rather their age is number one. It's their age, their sex. There's a lot of biophysical, psychosocial factors that go into why a particular symptom persists that long. For concussive injuries, the age kids tend to have persistence of symptoms a little bit longer. Females tend to have a persistence of symptoms longer, and it really is on a case-by-case basis. But you treat the patient. You don't treat the numbers.
Okay, thank you so much.